Welcome to the CTSNet Women in Thoracic Surgery and European Society of Thoracic Surgeons Women in General Thoracic Surgery webinar entitled Regions for Opportunity, State of Women in CT Surgery. This is webinar 2 of the three-part webinar series, Women in Cardiothoracic Surgery, Advancement Through Collaboration. Thank you for joining us. Please note this webinar is being recorded and will be available next week on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce the moderators for this webinar. Drs. Madhuri Rao, Dr. Sarah Pereira, and Dr. Cecilia Pompili. Dr. Rao is an Associate Professor of Surgery in the Division of Thoracic and Foregut Surgery and Director of Robotic Thoracic Surgery at mHealth Fairview. She also serves as Vice Chair of Diversity, Equity, and Inclusion for the Department of Surgery at the University of Minnesota in Minneapolis, Minnesota, and the United States. Dr. Rao also serves as the WTS International Affairs Co-Chair. Dr. Pereira is a professor of surgery at the University of Utah. She is also program director of the Integrated and Traditional Cardiothoracic Surgery Training Programs and surgical director of the Structural Heart Program at the same institution in Salt Lake City, Utah, in the United States. Dr. Pereira also currently serves as secretary for the Women in Thoracic Surgery. Dr. Pompili is an associate professor and thoracic surgeon at the University of Hull in England, in the United Kingdom. Thank you for leading this discussion. I'll turn the panel over to you all.
Thank you, John. I will go ahead and introduce our first two speakers for today. Thank you for our audience for taking the time to explore this topic. And we are thrilled to introduce this group of esteemed physicians to our audience. So our speakers, I'm going to introduce our two speakers. The first two speakers, Dr. Pallavi Purwar, and Dr. Vinitha Nair. So Dr. Purwar is a consultant thoracic surgeon currently affiliated with the Holy Family Hospital. She did her training in India at the National Institute of TB and Respiratory Diseases. She has over 10 years of experience in general thoracic surgery and has made significant academic and clinical contributions. She's won several prestigious awards and honors, and she also participates in various public education and outreach activities. Thank you, Dr. Purwar, for being here today. Our other speaker from India is Dr. Vinitha Nair. Dr. Vinitha Nair is an assistant professor at the Government Medical College in Kottayam, Kerala. She has proceeded to gain several international fellowships as well throughout the world, across the world. She has been practicing since 2014. Her significant contributions, to name just a few, are setting up a heart and lung transplant unit in Kottayam and also a pediatric surgical unit in the same hospital. She's worked on several projects in community health as well. And she has over 30 peer-reviewed publications and memberships in several international organizations. Thank you, Dr. Nair, for joining us today. I'm going to hand over to Dr. Pereira to introduce the other speakers.
Hello, everyone. Thank you for joining us today. I really apologize. My laptop crashed right before this meeting, so I hope you can see me and hear me, and I really appreciate CTSNet hosting our webinar today. It's my privilege to introduce Dr. Sharon Ong, who I've admired from afar for so many years. Dr. Ong is a general thoracic surgeon at Surrey Memorial Hospital, affiliated with the University of British Columbia in Vancouver, Canada, in British Columbia. She's a clinical associate professor and director of the Wellness Committee for the University of British Columbia Thoracic Surgery Fellowship Program. She's also chair of the Equity, Diversity, and Inclusion Association for the Canadian Association of Thoracic Surgery. Welcome to Dr. Ong. We also are fortunate today to have Dr. Tesfaya Bhatta join us. She is a consultant of Thoracic and General Surgery at the Addis Ababa University, affiliated with the College of Health Sciences, and I believe the first thoracic surgeon in Addis Ababa, Ethiopia. Welcome, Dr. Tesfaye Bata, to our panel and session today. Dr. Pompili, would you like to start us off with our first discussion?
Thank you so much. And yes, I would like, first of all, to thank CTSNet for hosting this, for the second year, of course, this joint effort between the AATS, and especially I want to mention here Dr. Antonov and Dr. Molina, who really wanted this project to go ahead together with the ESTS Women in General Thoracic Surgery Committee. So it's a really privilege to be part and to carry on with this project also this year, and of course to thank all the panelists, moderator today to join. I also will pass some apologies from Dr. Sefait, because she unfortunately had unforeseen circumstances and she will not be able to join today, but she will participate even during our ESTS in Budapest to, of course, bring her experience in Ethiopia, and as our first general thoracic surgeon to bring across the border the general thoracic environment. So I would like also to mention to our viewers that they may type their question for the panelists at the time by using the Zoom Q&A function. There will be also one presentation, of course, by each panelist for a total of 3 presentations. And we try to implement this Zoom poll, which will appear before each presentation. And I guess the first one is already on. So we encourage you to answer each question, and the results will be shared directly after. And of course, after the 3 presentations, the panel will open to general discussion with input, of course, from the Q&A. So we will leave this poll question for a moment. How do you perceive the current representation of women in cardiothoracic surgery in your region? And unfortunately, we have almost 70% of the respondents saying that is still poor. And this is, of course, what we are trying to improve and to share between us today, and to make sure that we are able to identify specific need and also gaps where at societal level, but also at institutional level, we can improve faster the representation of women. So without further ado, we will now, we are very happy to introduce, of course, Dr. Purwar and Dr. Nair to open with this shared presentation of cardiothoracic surgery in South Asia. Thank you so much again for listening.
Thank you for the nice introduction. Thanks, Maddie. Thanks, Sarah, and thanks, Cecilia. And thanks, CTSNet, for giving an opportunity for us to present the status of women in cardiothoracic surgery in our part of the country. So myself and Dr. Pallavi will be talking on this common presentation. And let's start by the status of women in cardiothoracic and vascular surgery in South Asia. As both of us are from India, we would like to present the statistics from India first, and then we'll go to the international statistics in other countries in South Asia. So we'll start with the pioneers in India, the proposed problems of ladies in our field, what is the data showing their plights, and we would like to discuss the results of a survey we conducted in our country and to look the way forward. So, as you know, cardiothoracic and vascular surgery has been a male-dominated field since its inception, and it lagged behind almost all of the surgical specialties in integrating ladies into this specialty. But if I have seen further than others, it is by standing upon the shoulders of the giants. I remember fondly at this moment Madam Nina Braunwald, who was the first woman to get trained in cardiothoracic surgery and performed the first human mitral valve replacement, and was the first woman to join the Harvard surgical faculty. So after there are so many courageous ladies from our part of the world. Dr. Srimati Sheshadrinathan, Dr. Ratna Magotra, Dr. Abha Chandra, Dr. Prabhata Rashmi, Dr. Supri Chopra, and Dr. Ananda Bhalla are only a few names in a longer list of enthusiastic and courageous ladies who took up this specialty in the earlier years and really paved the way and showed the light for us youngsters to enter into this specialty. And some of them are real entrepreneurs besides being cardiac surgeons. Some have held very good leadership position in national associations, and some have dedicated their whole life for the betterment of ladies in cardiothoracic surgery. But still, the barriers in the workplace continue to be sticky floors and the invisible glass ceilings. Ladies find it difficult to rise up from the sticky floors in their workplace, and even if they try to climb up the ladder, they find an invisible glass ceiling because they are not able to climb up or get better positions as higher positions, even though they are equally trained and equally qualified as their male counterparts. There are many common forms of discrimination faced by any lady, for that matter, in any surgical specialty, but particularly to the CTVS programs. And structurally, fewer women are admitted into CTVS programs. 15 years back, I was also told by a renowned institute that CTVS is not a job for ladies. And I'm sure that many ladies in this profession have heard this statement so many times. And lack of maternity leave policies, although even in India, it's a legal policy, but still it's not implemented in many of the CTVS programs. The workplace culture is often not very encouraging to the ladies. They assume that the women are less fit for long hours or emergencies in a specialty like CTVS, which is really technically and physically demanding. And ladies are often disregarded by colleagues and patients who prefer male surgeons to operate upon them. Concern on work-life balance is a real big issue because the domestic responsibility of being a mother and a wife is much more sometimes than a cardiothoracic surgeon. Unequal employment opportunities, unequal wages, and unequal opportunities for promotions add to the plight of ladies in this field. Limited mentorship. Gender concordant mentorship is often not an easy one in cardiac surgery because there are only very few senior women in leadership positions in this. So lack of role models often discourage young surgeons to take up this specialty as their own one. And they often get warned from seniors against joining the specialty. And comments like, "You are too gentle for this field," and "Are you sure you can handle heart surgery?" ring in the ears of ladies many a times in our specialty. But what I feel is women in CTVS come to this specialty by passion, unlike many others who come by chance. They undergo same rigorous training, the same board certification process. They are measured by same metrics, but it's often seen that ladies need to work harder than male colleagues to reach the same reputation in the same department. And they have to fulfill more duties in personal life. Wife and motherhood are very important responsibilities. Let us see the gender disparity study in India and published in 2024. Out of 203, 82 participants were ladies, and most of them, 60%, were young ladies in training in cardiothoracic surgery, less than 30 years of age, and 62.5% reported facing gender-based discrimination, which is a huge number actually. And the representation of women in CTVS remains extremely low in India and even lower in academic and leadership roles. But the ladies who are in cardiothoracic surgery experience very high rate of overall career satisfaction. And they all feel that motherhood and family responsibilities had an impact on career progression among women. And there was a tendency for these girls to be single. 50% of the girls who attended these participants were single, and 1/3 of the married women had no children. And they were all committed. The discouragement from joining the specialty and gender-related stereotyping were also reported by all the participants. The motivators and barriers to a career in cardiothoracic surgery was studied among the general surgery residents, among 618 general surgery residents in India, of which 25% were females. They found that in first year, there were so many people who were enthusiastic to take up cardiothoracic surgery as a profession. But when they reached the final year of their training, most of them found that lack of mentorship and female role models are a significant barrier to come and take CTVS as a career. So, but many literature and studies have proven beyond doubt that women in CTVS have better patient-physician interactions, Ladies have greater willingness to collaborate. They have superior judgment when selecting patients for surgery, and they're more likely to follow evidence-based guidelines and provide patient-centered care. And gender of a surgeon does not impact the outcome of surgery. And even it is proven in many literature that female patients get the best outcome from female surgeons than their male colleagues.
So now if we talk about women in thoracic surgery, a pure thoracic surgery training program started in our country just in 2012. So of the 30 trained thoracic surgeons, 1 in 3 are women. So the ratio is much better. And since it's a smaller community, so we had a personal communication with most of them. And what we have noted is that there is no discrimination during training. So women are not feeling stifled at the time of training. There is no bias in both acquiring skills and performing their skills. There is a good work-life balance, but here I must say that the work-life balance is slightly better here because most of the initial thoracic surgery programs do not have lung transplant as part of their program. So it's evolving still. So our thoracic surgery program itself is in its nascent stages. But yes, there are challenges which women face in the private sector. The government sector, mostly they'll get good communication with patients, and the patients are not choosing the doctor. But when they move to the private sector, the patriarchal bias of our society does play a role, whether it is the people who want to get the treatment or the physicians who need to refer the patient to you. On both those counts, women face some sort of discrimination. But most of us feel that over years, I mean, you spend 5 to 7 years in the specialty and then this kind of dilutes and then you start connecting with patients. But this was what our baseline knowledge was. So we decided to conduct a survey to understand exactly what women who are in either cardiac or thoracic surgery think today. So this survey is not talking about general surgery, people who are aspiring to be CTVS or thoracic surgeons, but those who have already chosen this as the specialty and what is their outlook. So we had 128 responses. Majority were from India, 106, but we also had responses from Thailand and Turkey. The 2 from UK and US are people who had actually migrated from India overseas for better opportunities. When we looked at the regional distribution, we found that we had representation from almost every state of the country. Although the more dense, more hospital-dense states like Delhi, Karnataka, Maharashtra, Tamil Nadu, Gujarat had better representation, but we got responses from all across the country. When we look at the age group, 73% of our respondents were less than 40 years of age. This is also because even cardiac thoracic surgery was not considered a specialty for women very strongly in the years before, and now it is changing. And the second part of the thing is that most of our reach has been to the younger generations. So we have a 73% population which is less than 40 years. But the institute of practice is fairly equivalent. We have people from the government sector, the private sector, and pure hardcore educational institutes. So majority of our respondents, 56%, have done a 3-year post-surgical training program in cardiothoracic surgery. 27% chose cardiothoracic surgery as the specialty of choice right after their basic medical school training. And 6%, that is 8 out of 10 trainees of thoracic surgery, since it's a nascent program. So 6% representation is doctorate of thoracic surgery. So the biggest chunk of people who are focused today is mostly on adult cardiac thoracic surgery or adult cardiac surgery or pediatric surgery, but thoracic with its standalone program is picking up now. So when we understand their current roles, we had nearly 64% who are still not senior enough to take independent decisions. So they're either trainees or associates who are parts of the program who are still in the growing curve of their careers. 21% of our responders were independent consultants and 14% had senior leadership roles like being a professor or a chairman. When we look at the time spent in CTVS, nearly 70% of the women who have responded to the survey are less than 10 years of time in cardiothoracic and vascular surgery. And there's only 8% who have spent more than 20 years in the specialty. Again, showing how things are changing for women in cardiothoracic surgery in Southeast Asia, especially India. So when we looked at their proportion of time dedicated to research, then it's a dismal figure for India. 84% are really not keen. So nearly 50% spend less than 10% of their career time into research. And the same goes for additional training after their core program. Here, as you can see, 26% only like to upskill, and the rest are just settling down with what they've learned in their basic training programs. But this is what we want to focus on. 90% of the women who are in cardiothoracic surgery today in Southeast Asia region choose this as their primary specialty, not because of any other reason, but because they're committed and they want to do just this. It's not mentorship influence, but that's just 7.6%. It's not that they've been exposed to the specialty. It is because they have seen during their internships and their medical school trainings and chosen this as their passion for life. We found that 74% of the respondents felt that they had good mentorship, but it's again a dismal figure that only 5% has women as mentors for them. So we're hoping that soon it's going to change, but that's how it stays today. Nearly 50% have noted gender-related challenges. The 7% who are unsure are still very early in their training. So it's like a large number of women do accept that there are still gender-related challenges, and nearly 50% are saying that there are no institutional policies for gender equality. But this is what has changed. This is what I want to focus on: the support during training. Despite the 50% claiming to have lack of institutional support, 63% have rated that they had excellent to good support during their training, where vis-a-vis their training opportunities, the exposure that they got in the specialty, and only 13% felt that their training was poor or very poor. So especially on the training front, I think both in the cardiac and the thoracic services, women are being more inclusive. But for career advancement, unfortunately, the figure is still dismal. Only 40% will have an adequate career advancement, whether it's their pay, whether it's their patients, or it's their promotions. But at least the training part, we're moving forward. So 37.5% of the women said that they do some leadership roles in their day-to-day activities, whether they are working as a consultant or as a chairman or a senior consultant. It's still a small number, but this again reflects that there were so few women to even take up the specialty that it sounds like a positive number to me. Then we asked these ladies, do they find their workplace to be inclusive enough for decision making? And 70% are somewhere in middle, that is somewhat inclusive or somewhat exclusive or a neutral. 25% feel that they've worked in really good departments where it's actually as good as working with complete inclusion, and 5% have had a lot of harassment during their training. So another question that we posted was, have you ever experienced discrimination or harassment based on gender at work? And it comes as no surprise that 60% have either witnessed it or personally experienced it. That brings us to the need for these female role models, the women who have to be in leadership positions to guide and help us all sustain through this process. And that's what our respondents also agree. So we wanted to know the biggest challenge. And here I would say that I had a bias. For me, I thought that gender bias, which is 20% in our survey, would be the most important thing that most people will think about when they talk of the biggest challenge. But no, it's work-life balance. And it's so bad that, as you can see in the chart here, that of the 90% women who were 100% committed to take up cardiothoracic surgery as their career, nearly 46% have thought at some point in their career that they want to walk away. They want to switch to something else. So when we talked of the work-life balance, it's like the same thing. 13% very satisfied, 14% very dissatisfied. Majority are struggling somewhere in the middle. But this is a metric which, again, at least for us, it looks like a positive, although it may look very bad otherwise. Do you feel supported in balancing family and professional responsibilities? Just 15 years ago, the answer was no for 98% of the women. And now the answer is no for only 40. So we've moved a long way ahead. I think there's a bigger road ahead, but this is a bias that exists in our society, like the patriarchal norms. I would like to take a minute here to explain what we mean by patriarchal norms. it's the entire fabric of the society, irrespective of whether you're educated or non-educated. Our own society has this bias against women doing certain jobs. Like if I take example of my upbringing, my father did not allow my mother, who was well educated, and my father is a PhD, to take a job. So she could not have a career. Another patriarchal bias is that when I was younger, if I wanted to get a dental workup, I needed a dental workup done. My father would not go to a lady dental surgeon. So that's how deeply ingrained it is in our society. Uh, and so, yes, nearly 46.9% women feel that their career opportunities get restricted because of this patriarchal bias in the society. And only 37.5% are seeing the norms to be changing. When we try to find out what is the major hindering factor in these patriarchal norms, to find out how we can actually change. So, as expected, nearly 30% talk about bias in the minds of the patient itself. So the patient himself is or herself is not sure whether it is safe to get operated by a lady cardiac or a thoracic surgeon. The second is the bias in the minds of our fellow colleague doctors, who need to send the patient to a cardiothoracic or a thoracic surgeon. And 25% of them, whether it is because of their personal networking or other comfort zones that they have, they are very reluctant to send patients to women cardiac and thoracic surgeons. So, our final two questions were, what are the initiatives on a systemic level that would help change the situation for gender equity? And the three major takeaways from this were, one is flexible work policies. People want to manage, have a balance between their work and their life. They want to have time for their kids as well. The second is mentorship programs. And the third is institutionalizing gender bias policies. While in training, the bias is coming down, but this needs to be institutionalized. And for that, a lot of women feel that leadership training can be the way forward. Another interesting question was how we women can help each other. And here, this is what I think, and I want to highlight this: fight for your right, believe that you are equal. I think in this part of the world, we as women have to first identify within ourselves and support each other in saying that no, we are not going to take the discrimination, we are not going to take the bias, we're not going to try to prove ourselves to be better, that we have to work twice as harder to just prove equality. We're going to believe that we are equal. We're going to have more women in leadership roles, and we are going to make sure that there is no gender bias for skills. It's not an automatic birthright just because of gender that some people should get it better than the others. Another interesting point that we had in the survey was a reverse bias. I personally feel that this won't be a great thing to do because two historic wrongs don't make a right. Vinita?
So having talked so much, it's time for us to rise away from the sticky floors and break the glass ceiling. We know the courageous ladies have already started breaking the glass ceiling in the cardiothoracic surgery. If we see the percentage of ladies in cardiothoracic surgery over the last few decades, from 0% in 1970s, it has risen up to a position of around 3% in 2025. And this is a very important growth in the CTVS society. And we see the chart, the graph is being increasing in its height. And I'm sure that in the coming years, it will be skyrocketing because so many ladies would like to follow their passion and enter the specialty, irrespective of all the challenges. They are ready to face these challenges and take up the career of their choice. The situation is not much different in other South Asian countries. When we take the percentage of ladies in cardiothoracic surgical specialty worldwide, it's around 8%, with North America and Europe having a better situation with around 10 to 20% of their cardiothoracic workforce being ladies. But South Asia as a whole, when we consider, it's around 4%. And when we come to the rate of women cardiac surgeons per 1 million population, it's very much underrepresented. Taking South Asia as a whole, it's just less than 0.05. And taking the rate of women cardiac surgeons per 1 million women population, it's even underrepresented in South Asia compared to North America and Europe at less than 0.1. So here, I would like to say that we have identified work-life balance as a major hurdle to the ladies. But what we should do, as policymakers, there should be good working policies. Whether it's a male or a female, everybody has the right to select the profession of their choice. And it has become a recent trend that ladies are now becoming more focused on career, that it's a tendency towards staying single and to take a decision of having no kids, even if married. And this, I think, gives a slightly wrong idea to the junior girls that if you want to pursue a career in CTVS, you should not think about family, so that you should remain single or should not complete the family. And we personally don't think this is a very healthy way forward. So we should try to make work-life balance a good for anyone who would like to pursue their career in CTVS. It's not the gender. This is not a gender fight. This is a human fight. Everybody has the right to dream, to take the subject of their choice. As rightly said by Roosevelt, the future belongs to those who believe in the beauty of their dreams. Thank you.
Thank you, Dr. Nair and Dr. Purwar. We'll save the Q&As for after the second presentation. So as we're preparing for the second presentation, we have the second poll question up. What do you see as the biggest barrier to gender equality in CT surgery globally? This is interesting, very, very similar to what Dr. Purwar and Dr. Nair just described on their survey, work-life balance challenges. Obviously, a great need to, and systemically and organizationally address this. And I think we as the current generation of surgeons, be it male or female, that's going to be a big responsibility for us. And then mentorship and sponsorship and stereotypes come in as a second, which again, I think these are all identified issues, which I think, it's going to be upon us to initiate remedies for this. And it's going to be a long process, but I think as a group, we can do it. Thank you.
Thank you, Dr. Rao. It's my pleasure to move on to our next presentation by Dr. Ong. We will have time to talk about the great presentation by Drs. Nair and Purwar later in the Q&A, as it was really a great talk. Our next talk will be with Dr. Ong on establishing a sustainable thoracic program, which thank you for this presentation.
Thank you, everybody, and good morning from Vancouver, BC, Canada. And I just want to thank the CTSNet and the Women in Thoracic Surgery for the opportunity and privilege to share my experiences with you all. So it's a very different topic this time. It's just establishing a thoracic surgical program, different from the needs that we need to see in gender disparity in thoracic surgery. So I'm going to be speaking about my experience with going to Mongolia and establishing a thoracic program there. All right, so the collaboration for Mongolian Canadian was born out of a desire to provide a good surgical care in low-income countries. This started in 2016 when the ear, nose, and throat doctors coming from Surrey Thoracic Surgery have asked for a thoracic surgeon to assist them with a laryngopharyngoesophagectomy. So at that time, my partner, Dr. Ashrafi, was asked to join them in 2016. This was at the National Cancer Center of Mongolia. And while he was there, he was able to be underground, assess the need for the local thoracic needs, their resources, and what they have in experiencing the case volume for thoracic surgery. So just as a background, the National Cancer Center of Mongolia is a government-based hospital, and that has its own health insurance that's paid for by the government. It is the referral center for most cancer centers, and they do have thoracic surgeons already there. Most of them are very good with open surgeries, including lobectomies and esophagectomies. The local surgeons are willing and have the baseline skill sets already. And the goal for the collaboration was to advance them to minimally invasive thoracic surgeries. So the initial group was in 2016 that were visiting Mongolia, was Dr. Ashrafi as the primary thoracic surgeons, and we had some anesthetists and OR nurses who went. The role of the local surgeons, which are the Mongolian surgeons, started off with just assisting and observing how to do minimally invasive thoracic surgery. In fact, at that time, the NCCM, the National Cancer Center of Mongolia, has one laparoscopic tower that they shared amongst all the different surgeons. And when Dr. Shrafi was visiting, as you can see from this picture, it was reserved for their use so that they can educate and teach. This happened in 2016, 2017. The second phase of the program, as we saw it, was to transition over to more primary operators with the local surgeons, giving them and lending them more independence and leadership. At the second period between 2018 and 2019, the Canadian visiting group included nurse practitioner, as well as physiotherapist to assist with perioperative care and management. We also shared our pre-printed orders for post-operative and perioperative management, the order sets and protocols for lobectomies and esophagectomies. And in 2018, through the support and donation from the local Surrey Thoracic and Surrey Memorial Hospital Foundation, we were able to bring Dr. Bhattacharyya, who is the chief of thoracic surgery from Mongolia, to visit us in Surrey Memorial Hospital to 3 weeks. And this enabled him to see how we do our, how we operate in the operating room, what we do in on the ward, and the perioperative care that we do here in Surrey Memorial Hospital. Unfortunately, 2020 and 2021 happens, and COVID ensued, so we did not have any actual visits. So we had the yearly visits that we normally do in Mongolia, which is about a week-long visit. During this time, the communication was limited to WhatsApp messaging and emailing. The local surgeons, however, were very good in continuing with advancing their own skills, despite the fact that we weren't there, and they continued to persist doing hybrid or more minimally invasive type of surgery. And at the same time, during this time period, there were funds from international community, specifically Japan, assisted with funding infrastructure, resulting in new operating rooms and better post-operative surgical ICU beds. Thankfully, COVID went away, and our third period became 2022 to 2024. It's still ongoing local support, and we've been transitioning from them being the primary surgeons to just proctoring them. So we gave support locally, identifying their goals, improving quality improvement metrics, supporting them in initiating and developing a database and collecting outcomes. And proctorship kind of like happened during the visits, where they are the primary surgeons and we would proctor them intraoperatively. There was also the bidirectional partnership, where we were able to support a second Mongolian surgeon, female thoracic surgeon, Dr. Aza Badamkhand, who came to Surrey Memorial Hospital for the summer. In 2022, we were also able to donate a Stryker minimally invasive endoscopic platform tower that was dedicated to thoracic surgical use only at NCCM. We had also been able to, thankfully been able to bring a medical device technician engineer, a Stryker rep, who was able to come and use her own time and volunteered her time and expertise to teach the local medical device technician how to maintain the endoscopic platform tower. We also brought some bronchoscopic equipments and monitors. And at this point, we were able to teach the anesthetists how to place arterial line, double lumen intubations, and perioperative care. The scope of practice expansion have also expanded further. And in 2022, we were able to do our very first true minimally invasive esophagectomy at NCCM. And this is also the transition year, as Dr. Ashrafi has put in 5 years of visitation at Mongolia already. And this is when I started coming in to assist with them too. This is the year where we did our first MIE together to show them how to do it, the Stryker tower, as well as the anesthetist learning how to do double lumen tube, arterial line, and whatnot. We were doing a lot more proctorship at this point, as they were very good in doing the surgery already, and just giving them pearls and techniques, pitfalls, and how to troubleshoot while they're in the operating room. You can see we've also have nursing care and perioperative teaching here, and a very low-tech simulation where we take a cardboard box and show them how to do intracorporeal tying and suturing. So what did we learn with this outcome is that we actually were able to witness like more transition to minimally invasive thoracic surgery. By 2024, they were doing mostly, hybrid, if not pure minimally invasive esophagectomy. And you can see the trend that when they started in 2022, they only did 4 of these minimally invasive esophagectomy. By 23, 24, they were able to do 32 to 33 MIEs. And similarly with their VATS lobectomy, they started with only 8, and by 2024, 22. So they were much more confident in doing minimally invasive thoracic surgery. Local endeavors are obviously very important at this point, and they've been very good at pushing, trying to do more on their own. They've actually presented their own data and outcome at their regional and national meeting in 2024, and they won the Best Presentation Award. They've also been able to secure local fundings to send their surgeons for more fellowship and observership. They went to Japan, Taiwan, France, and most recently, HUGS in Switzerland. They're also developing a thoracic surgical training program now and currently have 2 fellows in training. Our experience was presented recently at the 104th annual AATS meeting in Toronto, and we were able to do a poster podium presentation, and it's also now published at the Open JTCVTS. So what did we learn here? To maintain a sustainable program, we really need a long-term approach, and it requires knowledge exchange, resource sharing, and local capacity building. Ultimately, the goal is that the international support should gradually decrease as the local surgeons and hospital build its own self-sufficient thoracic surgery program. In essence, it takes a lot of time, investment both financially and time. So I put together some practical steps to consider and how to establish long-term partnership. You really need to develop a memorandum of understanding between the local hospital and international group. This should outline the long-term goals, training, research, and technology transfer. It's good to have sister hospital partnership, for example, Serum Memorial to the National Cancer Agency, pair the local hospital with high volume thoracic surgeons in developed countries. And I think it's also very good that we have AATS and WTS that we can partner with global organization to see and fund these scholarships. Continuous education and training for local surgeons is obviously imperative, allowing local surgeons to visit, observe in high-income countries, telemedicine, virtual mentoring system, as well as simulation-based training. And we need to build sustainable local capacity. We need to train the trainer models, focus on training so that we work alongside and proctor instead of just performing surgeries and leaving. We should also exchange programs, rotating visiting professorships where the international surgeons can visit the local hospital 1 to 2 weeks per year. We can strengthen their research and academic collaboration. I think doing research programs, doing quality improvement only leads to a stronger program for the local communities and hospitals. They can increase their local participation in global conferences, exposing them to other type of working environment and programs. We should fund and research sustainability, ask and advocate for the local government fundings and capacity building, engaging nonprofits for financial and equipment support, and also seeking corporate and philanthropic partnerships. Lastly, we should also monitor and continuous improvement, like track surgical outcome, complications, survival rates. It's important so that they can see the improvement and be able to be encouraged by that. Finally, here's some pictures from Mongolia. The one on the right side is Dr. Aza Bagadam from NCCM, and she's the only female thoracic surgeon currently in Mongolia. Thank you, and as they say in Mongolia, Barla.
Thank you, Dr. Ong. That was really spectacular and really great work that you're doing. Our third question has to do with initiatives that all of us believe would be most effective at improving gender equality in CT surgery internationally. Great, so it's almost a tie here with encouraging flexible training work arrangements, 50% of respondents, followed by increasing mentorship and sponsorship programs, which I think we all agree. You know, I have been very fortunate to be involved in women in thoracic surgery, and we do now have an international relations committee within WTS that's actually led by Dr. Maddie Rao and Dr. Ron Zong. And I encourage all of you internationally to join us. I think that in addition to our work-life integration balances, it's always difficult for us to travel and have, the rotating professorships and rotating faculty that you present, Dr. Ong. And so I'm wondering if you have any ideas on what we can all do better to help collaborations, not only between US surgeons, but between international surgeons, and how do we help mentor and sponsor each other at each levels, from training to, I'm 20 years in and I've never visited you in British Columbia. So how do we do that better in the future in terms of collaboration?
I think this is the perfect place right now, what we're doing. So WTS have done a wonderful job in, I think, promoting themselves and ensuring that people know that there are women in cardiothoracic surgery. Most recently, actually, because of WTS and STS, I've had the opportunity to visit Tufts University to do robotic programs with Dr. Lana Schumacher. And I would not have done that if I didn't know about STS and WTS work in robotics. And I think, promoting ourselves and ensuring that people know that there are organizations such as WTS and the Scholarship Foundation of AETS under Dr. Valerie Rush, encouraging international women to apply for fellowship. I think this is a great start, right? And then, promote and having these sessions and, like just listening to Dr. Nair and Dr. Purwar today, that's amazing. Like, I would not have even heard about the lack. I mean, we know that, I think, coming from a very Asian culture as well with my background and my upbringing, I can see that. But obviously, hearing about it and seeing the numbers, it's quite a difference, and an eye opener.
Absolutely. Dr. Rao?
Thank you, Dr. Ong. That was an amazing presentation and amazing work that you're doing. And back to Dr. Purwar's and Dr. Nair's presentation as well. That was, as Dr. Ong mentioned, it's really eye-opening to see some of those numbers, because a lot of times you hear things and people are talking about this stuff and you're like, dude, is that true? I don't, is that real, or are you just making up stuff? But seeing these numbers and putting it out there, I think just puts everything into perspective, and that gives us more than anything else. I think that gives us direction to say, okay, what do we need to do? Okay, we know that this is an issue, and this is what steps can we take. And I think a lot of this is across the world and just to different degrees. And just to give you a sense of the US as well, as you did mention some data there, in the US, it's about 8% of female representation in cardiothoracic surgery. STS is about 6%. Which is more than what we're seeing in Asia, but still a lot of room for improvement. And similar thing with leadership positions. 10% of chairs across the country are women. Not to say that women are not capable of it, but there are various things that are holding us back. And good thing is that there is an improvement. We are seeing an improvement across the world, and that's very heartening. On that note, I have a question, one for Dr. Nair and one for Dr. Purwar. So for Dr. Nair, I think one thing I noticed, and correct me if I'm wrong, but when you described training for cardiac surgery and when Dr. Purwar described training for thoracic, it seemed like there was more, was the trainees in cardiac surgery felt like they experienced more discrimination, whereas the trainees in thoracic seemed like that wasn't the case. So if you can kindly address that, if I heard that right, and what your thoughts are. And then I'll ask Dr. Purwar's question as well, so that you both can take over the floor. It seems, it's very heartening to see that male mentorship is playing a big role as well in bringing up women thoracic surgeons. With good support like that, I'm just wondering what the current systemic or organizational steps are at this point. What's being considered in a country like India to further help with that?
Yeah, thank you. So yes, you have rightly heard that cardiac surgery residents have a much more difficult time than a thoracic surgery resident. Maybe it is thoracic surgery is a little, I would say, a little extension of general surgery training, where you can practice with a good anesthesiologist in a center. But cardiac surgery, as you know, it's a big teamwork. you need to have a good cardiac anesthesiologist, a good perfusionist, a good ICU setup, a good theater setup. So on the whole, there is a lot of changes or differences between a cardiac surgical program and a thoracic surgical program. And in cardiac surgery, it's actually a very male-dominated field. And I personally had a male mentor. I never have come across a female mentor. I come across senior ladies very late in my career. And as rightly shown in the survey, I chose cardiac surgery 100% because of my interest. There was absolutely no role for anybody else to incite interest in me about cardiac surgery. And my first choice, second choice, and final choice in my life were to become a cardiothoracic surgeon. And I was lucky enough to get a good family support, both from my parents as well as my husband's side. I have a reasonably good work-life balance. And so I encourage those ladies who ask me about pursuing career in cardiac surgery. I first ask them, are you really interested? Are you really passionate about the subject? If you're really passionate about the subject, the second question I ask is, will your family support you? If you have a family support, great, go ahead. I never tell my juniors that having a family is an obstacle to taking a career in CTVS. And that's what I want to tell the young ladies who want to pursue a career in CTVS, that we should aim and we can have a good work-life balance if some policy change are there in our working culture. So it's basically a change in the understanding in the specialty. And in India, we are trying to improve the representation in the National Association, and we are on the way to creating some more leaderships from ladies, senior ladies, to get collaborated. Right now, we have a WhatsApp group, a lady cardiothoracic surgeon group with 92 members, and there are very senior ladies also in that. But we would like to take it into a national level so that we can discuss the issues, not in a common forum, but in a ladies forum, and help to provide more gender concerned or concordant mentorship to young ladies coming to this specialty. So that's what we are looking forward.
Thank you, Dr. Nair.
Dr. Rao, if you'll allow me, I'll just add to what Vinita said on the first question. I think the difference is, I would say that thoracic needs as much teamwork because there are many more complexities on each specialty to their own thing. What I feel is that we are at a different stage of evolution. When cardiothoracic surgery programs were being brought up and they were being institutionalized, at that point, the discrimination was much more. And today, even the cardiothoracic surgery residents, the young trainees are having a much better mentorship than they used to have, say, 10 years ago. So what I feel is that our specialty only started 10 years ago, and that is the reason why we are a little more on the being more rational and more frontal, because the society has changed. Till 10 years, when I did my general surgery training, there was a lot of discrimination, and all the time the question was, they want to put you down, that you are not fit for this. But now the culture has changed. Now there are women in general surgery who are in huge numbers, and they're all choosing their passion. So I feel that slightly it is about the evolution of stages of the two societies, the thoracic and the cardiothoracic. Coming to the next question, why male mentors? Because that's what has changed. I spoke to Dr. Ratna, whom we mentioned, and she tells me that in 1980s when she was doing, and she became the head of the department of a very famous institute in Mumbai, she felt that she had a much better life than her counterparts in the US. And her answer to that was that it was not because there are not biases and all, but because she said that it's the mindset. They chose to think that they want to go ahead. So for me, she gave me a very interesting advice. You got to ask the male colleagues who were working under me whether they had a problem, because it's both ways. So what I feel is that it's not the male or the female mentorship, but just the fact that the community is opening up to women doing this better and moving forward with it. That is there for the training, but we would hope that we get this for our job positions, we get this for our promotions, we get this for sending some of our female colleagues outside to learn better so that they can grow in their careers much more here. I think those are the policy level decisions that we are looking for going forward.
Thank you, Dr. Purwar and Dr. Nair, Dr. Ong. We have only a few more minutes. This has gone very quickly this hour. I wanted to just make a statement of how encouraging your presentations were. I was excited to see that 30% of women in India are now in training programs. Also in the US, 30% of our trainees and learners are now women in our integrated programs. And so I think despite the fact that we only have 2% of women practicing cardiothoracic surgery in India and 8% in the United States, I think that all of us are really trying to dedicate a huge amount of time to mentoring and training our next generation. And I really thank you all for that. It's been really a privilege to see your great presentations and to see you on this webinar today. And I wish we had a few more hours, but I'm going to let Dr. Rao conclude.
Thank you. I know we just have a couple of minutes here, but I do want to address quickly a couple of questions that came up on the Q&A. There was a question about Dr. Bala being interested in joining the STS and WTS. We are most welcoming of international members, and we are specifically working on making this more accessible and more, the information being better disseminated. But as of now, if you go to the websites and type in membership, there's already facilities for international members to join in. And the membership rates are actually much lower than for the US members, US and Canada members. So it's already widely open. So you should be able to access it through the sites, but we are working on processes to make it more easily accessible. And then there was one more question, and then I'll conclude. There are some suggestions about opening scholarships. I think these are all great ideas that we can, build in a forum. What is cardiothoracic residency? Someone wanted to know about cardiothoracic residency in India for IMGs. I think I would direct that question to Dr. Purwar and Dr. Nair. If you can please share your email, maybe the attendees can reach out to you. And then there was another question about, facilities in the US and UK for women residents and cardiothoracic surgeons as opposed to other countries. I think, to be honest with you, I think, yes, there have been some measures. We're still working on more things like a more extended maternity leave, not having to take it out of your vacation and just dedicating time for maternity leave, for example, or parental leave, not just maternity leave, making sure that both partners are involved. And so there have been changes in the American Board of recommendations from the American Board of Thoracic Surgery and the American Board of Surgery to make that more viable. So things like that have been looked into, and then mentorship scholarship programs, of course. Any thoughts on that, Dr. Pereira? If not, I will conclude.
Yeah, I've been very actively involved in some great scholarship programs from Women in Thoracic Surgery as well as STS and AATS. Unfortunately, the majority of our US organizational scholarship programs are only open right now to students and residents in the United States and Canada, but we are working towards having more international collaborations, particularly with WTS in the future. So keep an eye on the websites. And please, any US and Canadian folks watching this, please apply to the scholarships. They're really a great experience.
Thank you, Dr. Pereira. So I think if we don't have any other final comments, I'd like to conclude by saying thank you again. Thank you, Dr. Ong, Dr. Purwar, and Dr. Nair. Thank you, Dr. Pereira, and Dr. Pompili, who unfortunately had to leave a little bit early. And thank you so much, John, from CTSNet, making this happen. And this is just wonderful. Thank you.
Yeah, thank you all. It's been great.
Thank you.
Thank you for attending the CTSNet Women in Thoracic Surgery and European Society of Thoracic Surgeons Women in General Thoracic Surgery webinar. As a reminder, a recording of today's webinar will be available next week on ctsnet.org and CTSNet's YouTube channel. Please take a moment to fill out a brief survey that will appear as you leave this session. Your feedback is greatly appreciated. Look forward to the final webinar in this series, Webinar 3, Mentorship and Sponsorship, which will take place at the same time on May 15th. Registration is now open. Have a wonderful rest of your day.